Welcome to the Weekly Neurology Deep Dive. We're glad you could join us again as we take a closer look at some key research impacting neurology.
Yes, glad to be here.
Today, we're really going to unpack a study that I think has some potentially significant clinical implications. But before we jump in, just the usual quick reminder, this deep dive is purely for educational purposes. No commercial goals here, it's just our summary of the research.
And we always recommend reading the full paper yourself to get all the details and the full context. Definitely worth it for this one.
Absolutely. So the paper we're focusing on is from Busanaro and colleagues, published this year in Neuroimmunology and Neuroinformation. It's titled Serum Autoantibody Titers and Neurofilament Light Chain Levels in CASPR2 LGI1 Encephalitis.
Right, and this paper addresses a persistent problem in managing autoimmune encephalitis, specifically the CASPR2 and LGI1 types. The issue is the unpredictability of long-term cognitive problems. We know, maybe up to about 65% of these patients can struggle cognitively later on, but we haven't really had good early markers to tell us who's most at risk.
So that's our mission today, then, to really understand the clinical value of these two potential biomarkers they looked at: serum autoantibody titers and serum neurofilament light chain levels, or NFL. What do they actually tell us as clinicians about how our patients might do long term?
Exactly. What's the practical takeaway?
Well, for those of you short on time, here's the essential takeaway right now. This study suggests that serum neurofilament light chain, or NFL, measured right at the onset of CASPR2 or LGI1 autoimmune encephalitis, seems to predict the risk of long-term cognitive issues.
Whereas the autoantibody titers, well, definitely useful for tracking the disease stage and, importantly, for identifying relapses, they don't appear to predict those long-term functional or cognitive outcomes.
So a really key difference there. We'll get into the specifics, the data behind this, and how you might use this in your practice right after we quickly cover the study setup. Okay, so let's unpack the study itself. How did they actually go about investigating these biomarkers?
Well, it was a retrospective cohort study. They gathered patient samples from 6 different neurology centers in Italy. They were specifically looking for patients who tested positive for CASPR2 IgG or LGI1 IgG antibodies using a live cell-based assay. And crucially, these patients needed to have a definite diagnosis of autoimmune encephalitis and at least 2 serum samples taken over time.
Over time being key, how far apart did the samples need to be?
More than 60 days apart. The idea was really to track changes longitudinally.
Makes sense. So getting that dynamic picture.
Precisely. And they categorized the samples carefully. Acute samples were taken right at the beginning, either the first diagnosis or during a relapse, but always before starting immunotherapy. Then remission samples were collected more than 2 months after immunotherapy for an acute event, aiming for a more stable phase.
Right. And how many patients did they end up including?
They enrolled 23 patients in total. About 15 had LGI1 autoimmune encephalitis. Around 7 had the CASPR2 type. And there was 1 patient who was actually positive for both antibodies.
Okay. And the demographics?
About 44% were female, and the median age at diagnosis was 63, so tending towards an older population.
And clinically, what did they look like at onset? What were the common symptoms?
Seizures were extremely common. About 96% of patients had them at onset. Psychiatric symptoms and cognitive impairment were also very prevalent, both seen in about 65% of patients right from the start.
Wow, so a very significant burden from the beginning.
Definitely. And they followed these patients for quite a while. The median follow-up was 37 months.
Over 3 years, that gives some weight to the outcome data. How are those outcomes measured?
They use standard scales. For functional outcomes, the Modified Rankin Scale, or MRS, and also the Clinical Assessment Scale in autoimmune encephalitis. For cognition, they use the Montreal Cognitive Assessment, the MoCA, adjusting for education, with that common cutoff of less than 26 indicating impairment.
Standard tool's good. And the biomarkers themselves, how were they measured?
The serum CASPR2 and LGI1 IgG titers were done using a live cell-based assay, as mentioned. And the serum neurofilament light chain levels were measured using the human NFL Simple Plex cartridge. They also had a comparison group, 23 healthy controls, matched for age and sex.
Okay, seems like a solid setup. Let's get into the results. First up, the autoantibody titers. What did they find regarding disease phase and outcomes?
Well, the first key finding was that, yes, the titers do reflect disease activity. Serum titers in the acute phase were significantly higher than the titers in remission samples. And this was consistent for both LGI1 and CASPR2 antibodies, with the difference being highly significant, p-value less than 0.01.
So higher titers when the disease is active.
Exactly. And interestingly, the CASPR2 patients tended to have higher median titers, about 1.6400 compared to the LGI1 patients who had a median around 1.1280. That difference was also significant.
Okay, so titers reflect activity. Did they also track with treatment response?
They did. They observed that the titers generally went down over time and after immunosuppressive treatment was given. For example, the median titer reduction was about fourfold by 4 months, 12-fold by 10 months, and then quite substantially about 32-fold by the last follow-up check.
That strongly supports their use for monitoring treatment effectiveness then.
Absolutely. It shows they are responsive to therapy.
Now, what about relapses? This is often a big concern. Did titer changes predict or correlate with relapses?
Yes, this was another important finding. Out of the 10 patients in the study who did relapse, about 9 of them had positive antibody tests during that relapse. And even more telling, for the patients where they had samples from before the relapse, about 4 out of 5 of those cases, the relapse happened alongside an increase in their antibody titers.
Huh. So a rising titer could be a real warning sign for an impending relapse.
It certainly seems that way. It raises the practical question of whether we can use, serial titer monitoring to help define or anticipate relapses.
Very clinically relevant. But then, the big question, did these titers, especially the ones at the very beginning, predict how patients would do functionally or cognitively down the road?
And this is the crucial negative finding. The onset titers did not correlate with either the functional outcome measured by MRS or the cognitive outcome measured by MoCA at the later follow-up points.
So even if someone starts with a really high titer,
It doesn't necessarily mean they'll have worse cognitive problems later on. The initial titer level, while reflecting acute activity, just didn't offer that long-term prognostic information.
that is such an important distinction for managing expectations and planning care.
It really is. They also looked at patients who became seronegative over time. About 7 patients converted from positive to negative, typically after about 12 months. And interestingly, none of those 7 relapsed during the follow-up period after they turned negative, which was about 12 months median.
So becoming negative might suggest lower relapse risk.
It might hint at it, but with a caveat. Of the 4 patients they could follow longer after becoming negative, all of them eventually tested positive again after a median of about 10 or 11 months. So these seroconversions might just be temporary in some cases. We can't assume it's a permanent all clear.
Right, vigilance is still needed. Any other points on the titers?
Just a quick note, they found all patients were positive for the IgG4 subclass at onset, which is interesting because IgG4 is often linked to conditions where titers do track disease phase well. It just adds another layer to the immunopathology.
Okay, interesting. Let's switch gears now to the other biomarker, neurofilament light chain, NFL. We know this reflects axonal damage. What did they find here?
So looking at NFL, the levels were significantly higher in both the LGI1 and CASPR2 patient groups compared to the healthy controls. Much higher. The median NFL for LGI1 patients was about 35.3 picograms per milliliter. For CASPR2, it was about 31.4, while controls were down around 14.5.
So clear evidence of neuronal injury in these patients compared to controls. Significant difference.
Highly significant, yes. P-values less than 0.01 for both comparisons. It confirms there's definite axonal damage happening.
And did NFL levels also change with disease activity, like the titers did? Higher in the acute phase?
Yes, they followed a similar pattern there. The median NFL in acute phase samples was significantly higher, about 47.2 pgml compared to the remission samples, which were around 31.2 pgml.
Okay, so NFL also reflects that acute inflammation and damage.
Right. It tracks with the active phase of the illness.
But this is where it gets really interesting for prognosis, right? Did the NFL levels predict long-term outcomes?
This is really the headline finding, I think. Yes, the NFL levels measured at disease onset showed a significant correlation with cognitive outcomes later on. Specifically, higher NFL levels at the beginning predicted lower MoCA scores, meaning worse cognitive function at the follow-up assessment.
Wow. So NFL at onset actually flags patients at higher risk for cognitive sequelae.
Exactly. It gives us that prognostic information that the titers lacked. They found memory was the most commonly affected domain long-term, in about 55%, followed by executive function and attention, both around 36%. And that correlation between onset NFL and follow-up MoCA was statistically significant in their regression analysis, too.
That is potentially practice-changing, an early blood test that gives us a window into future cognitive risk.
It really could be. And another interesting point, while the NFL levels did decrease from the acute phase to remission, even at the last follow-up, the median NFL in patients remained significantly higher than in the healthy controls.
Huh. So even when patients seem clinically better, there might still be some ongoing low-level neuronal injury.
That's what it suggests, yes. Perhaps a subclinical inflammatory process or slower clearance, but it implies things might not be completely back to baseline neurologically even years later. P-value less than 0.01 for that comparison too.
Fascinating. Did the onset NFL predict anything else, like relapses or overall functional disability on the MRS?
Interestingly, no. According to their analysis, the onset NFL levels didn't correlate with the risk of relapse, nor did they predict the modified Rankin scale scores or other imaging findings at follow-up.
So its predictive power seems quite specific to cognitive outcomes.
It appears so, yes. Specific and potentially very valuable for that particular outcome.
Okay, so let's try to pull this all together. We've got two biomarkers here with quite distinct roles, it seems.
That's the main takeaway. Antibody titers are excellent tools for monitoring current disease activity, checking response to treatment, and importantly, flagging potential relapses.
But they don't tell us much about the risk of long-term cognitive problems.
Correct. Whereas NFL, neurofilament light chain, while also elevated acutely, seems to be the key player for prognosis. High levels at onset predict a greater risk of cognitive impairment down the line.
So how could this change our approach in the clinic? If we measure NFL at onset, what do we do with that information?
Well, it could allow us to identify those high-risk patients much earlier. And for those patients with significantly elevated NFL at onset, you might consider, perhaps a more aggressive initial immunotherapy strategy.
Or at least prioritize cognitive assessment and rehabilitation much sooner.
Exactly. Early initiation of cognitive rehab could be particularly beneficial for this group flagged by high NFL. Using both biomarkers together, titers for activity, NFL for cognitive prognosis, could really refine our management plans.
Makes a lot of sense. Now, we should, of course, touch on the limitations of this study.
Always important, yes. The main one is the relatively small sample size, especially for the CASPR2 group, only about 7 patients there. So generalizability might be limited, particularly for that subtype.
Okay, what else?
Well, detailed neuropsychological testing wasn't done systematically on all patients at both baseline and follow-up, so relying primarily on the MoCA is a slight limitation. Larger studies with more detailed cognitive tracking would be ideal for confirmation.
Right.
There's also the point that NFL levels in remission samples could potentially be influenced by damage from previous attacks, especially if the clearance takes longer than the 2-month window they used.
That's a fair point.
And finally, they didn't analyze potential confounding factors for NFL levels, like BMI or kidney function, which we know can influence NFL.
Understood. Important context to keep in mind. So let's just quickly recap the practical summary for everyone listening. The bottom line from this study by Buzzanaro et al. For your clinical practice is this. In patients with CASPR2 or LGI1 autoimmune encephalitis, measuring serum neurofilament light chain levels right at the onset appears to be a valuable tool. It can help identify those patients at higher risk for long-term cognitive impairment.
And knowing that risk early on can guide more tailored management, perhaps more aggressive treatment or earlier cognitive rehab.
Meanwhile, autoantibody titers remain crucial for monitoring the current disease state, how active it is, response to therapy, and especially for confirming or anticipating relapses.
But remember, those initial titers don't seem to predict the long-term cognitive or functional outcome. 2 different tools for 2 different but equally important jobs.
Well put. This has been the Weekly Neurology Deep Dive. A big thank you to our producer, Amer Gavanini.
And we hope this discussion has given you some useful insights from the latest research to potentially apply in your practice.
Before we sign off, here's something to think about. We heard that NFL levels, even after treatment and apparent remission, often remain elevated compared to healthy controls long term. So the provocative question is, what underlying, perhaps some clinical processes might still be ongoing in these seemingly recovered patients? And what could that mean for their very long-term neurological health and quality of life, maybe even decades later? Something to ponder.
Definitely food for thought.
Thank you all for joining us today. We strongly encourage you to read the full paper for all the nuances. We look forward to diving into more research with you next time.